Hello, welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association, which is keenly interested in pathology education. Our case today comes from the realm of bone pathology. It's a 14-year-old boy who is found to have a lytic lesion when he has persistent pain following a fall playing basketball. This happened several months previously, and he is still struggling with pain despite rest and rejuvenation. And so ultimately, an X-ray is taken. He does not have a fever or any other constitutional symptoms, but on examining his X-rays, we see that there's an abnormality here on one side in the greater trochanter area. Seen well here on the AP view, but also here on the lateral view, we can see that his right leg has sort of a mixed area of lysis and a little bubbly character to it. And here on the AP view, you can see there's a little bit of an infiltrative margin. Now, I've shown you this slide, here looking at the MRI that followed up that study. We see here his nice open epiphysis. And in addition to what's going on inside the bone, there seems to be a little bit of edema here and reactions in the surrounding tissue, which is significant. And notice the heterogeneity in the lesion as well. Light and dark areas indicating variable signal, variable amounts of solid, inflammatory water tissue, and so forth. Now, obviously, I'm not a radiologist, and I'm not going to go into the details of the differing imaging modalities here. But as you can see here with this fat-sensitive modality, there's heterogeneity here and loss of the more normal marrow signal that might be expected. So a lesion that's causing pain and has a lytic character, variable margins. There are a number of things to think about in this age group. This is a list I think I've shown before that includes Ewing sarcoma, Langerhans cell histiocytosis, osteomyelitis, and chronic recurrent multifocal osteomyelitis, lymphoma, leukemias possibility. Osteosarcoma maybe not such a likely possibility here, as it doesn't look to be particularly blastic, but those can be sometimes predominantly lytic. And then in older patients, multiple myeloma and metastatic disease enter into the differential as well. So given that differential, it was very appropriate that the surgeons approach this and seek frozen section consultation, which you can see here. So at low magnification, this looks to be sort of heterogeneous tissue. You can see the frozen section artifact. Obviously, we can't freeze the bone tissue itself, but some of the surrounding tissues and soft tissues are frozen. And although there are a lot of blue cells here, it's sort of a mixed population. It looks a little bit inflammatory, and you can see some sort of granulation tissue type response, despite the ice crystal freezing artifact that we have here. And we see a few giant cells and so forth, but it looks to be inflammatory tissue. And so given that differential, we might suggest that it's either osteomyelitis. We might think about eosinophilic granuloma, Langerhans cell histiocytosis, and we look through here to see if there's any sort of population that might have those characteristics as well. We do not see that. As we wait for this to come into focus, we see a little bit more fibrosing tissue here. This has been going on for some months in time when we get to it on this biopsy. But it does not look like this is any of the kidney bean-shaped round oval cells that you might think of with Langerhans cell histiocytosis. So we wait then and get the permanent sections, which confirm this very mixed inflammatory process, as you can see here. And I'm not going to spend a lot of time on that. This does not itself make a diagnosis of osteomyelitis, but certainly, again, favors an inflammatory lesion, as we saw on the frozen section. A lot of mixed inflammation, some chronic and some acute inflammation. So what does the bone look like? Well, here's a representative section that includes some bony spicules. And here we can see that this marrow space is packed. It's not normal marrow. This is a very dense, thick marrow space. And as we come back into higher magnification, we see that this is fibrin, neutrophils, inflammatory cells, and we have as well the cause for the lytic process, a great degree of bony resorption, as evidenced here with these sort of moth-eaten features that we have seen in a few other situations as well earlier. A lot of indentations indicating bone resorption. Looking at the bone itself, we notice here no nuclei in these lacunae. So there's a degree of bone necrosis. There are a few open or a few nuclei over here, one or two over here, but there are some broad areas where we're beginning to see total dropout of bony viability, which is helpful, not required for diagnosis. We also did a tissue gram stain on this lesion to attempt to help define organisms. Of course, culture would be done, but that may take a little bit of time to grow out, particularly if they happen to give any sort of perioperative antibiotics by mistake or by intention. And here we see that, in fact, as this comes into focus, we have a large number of clustered gram-positive cocci. And of course, this was not scanned at high magnification to allow you to discriminate those readily. But please take my assurance that these are, in fact, microorganisms and not a staining artifact. So there really are a lot of bugs in this sample to confirm the diagnosis of bacterial osteomyelitis. So thinking about acute osteomyelitis, I think there's sort of two differentials to bear in mind. One is that pediatric disease tends to be somewhat different from adult disease. And this is obviously a pediatric patient rather than an adult patient. In adults, it's usually due to gangrene, circulation problems, foreign bodies, secondary to joint replacement, those sorts of things. And we're not going to talk about that here, but we are going to talk about the pediatric disease. In this patient population, this disorder usually presents in the metaphysis. And this is due prior to the closure of the epiphyses to the particular architecture of the vascular supply, which tends to have penetrating arteries that enter beneath the metaphysis and then extend northward to the epiphysis, at which point they may make an abrupt turn, which interferes with the how should I say, the laminar flow of the blood and makes this a prime site for deposition of any hepatogenous borne bacteria, because this can occur in perfectly healthy children. Now, if the child has something like diabetes or juvenile rheumatoid arthritis or some other mildly immunocompromising disorder, such as chronic renal disease or something, that increases the risk significantly. Interestingly, there is a history of trauma in about 30% of these patients, such as our patient. It seemed to coincide fairly closely with his fall. The microorganisms that tend to be involved most frequently, Staph aureus. This is the one that gets in most easily, but you can also see group B strep, Kingella, Pseudomonas, tuberculosis less frequently, and Salmonella much less frequently, but for completeness, they're on the list. So our final diagnosis today is acute osteomyelitis, secondary to a gram-positive coccus. And the patient had the curettage of the lesion and packing with subsequent antibiotic treatment to combat the appropriate microorganisms potentially involved, and he recovered fairly quickly. In fact, perhaps too quickly, although he was informed that he should refrain from activity. You can't keep these young people down, and he was very soon after, much sooner than perhaps people would like, back on the basketball court, back riding skateboards, doing things that potentially put that bone at a little bit of risk of early fracture, but we hope for sufficient caution that he will do well. Well, thank you so much for joining me for this short vignette. If you like that, please hit the like button and share with colleagues that may be interested. And of course, we always welcome your comments or feedback directly or in the comment section below. And of course, we hope that you'll subscribe. We know that a lot of our viewers come and go and don't subscribe, but we hope that if you got to this point, this is of sufficient value to you that you'll want to subscribe. So until next time, thanks so much for joining us.